evening, friends. So looking at the small number of participants, apparently this is not an interesting topic for most general practitioners. Even if you think no, but I don't treat HIV/AIDS, that patient is yours. And what I am going to in this, I have been treating HIV/AIDS, and way back in 2008 or 7 or 8, Alka ma'am and myself and some other doctors, we had done a 4-Sunday workshop in management of HIV at JJ Hospital. I am sharing 2 cases with you, which could happen to any one of us. Preeti, I think you need to mute everyone.
Yes, sir, muted. You have to unmute yourself.
Dr. BDD, he was called to give a B complex injection to a HIV patient. He visited the patient, gave injection when there was no electricity but a candle. When he reached there, electricity had gone. So there was a candle on. And with that also, he gave an injection. And while trying to dislodge the needle, he had a needle stick injury. He knew this is an HIV patient. He was like struck by lightning. Never thought such things could happen. Later on, he acknowledged it was his big mistake. So he rushed home. He took a spoon, heated it, and branded himself so as to burn the skin. In case virus has gone, it should not go in further. And then 90 days of window period, he and his wife both lost almost 10 to 12 kilos each. They both kept crying. जिएंगे तो साथ में, मरेंगे तो साथ में. 3 months later, the report showed it's negative. So he was relieved. This is another, like it is actually case 2. Dr. HN, a very firebrand GP, seeing almost 60 patients each shift in a matter of 3 hours. 20 patients per hour, very quick reflexes, almost zero latent period. On a busy Monday, a 7-year-old boy rushed in by public with a CLW on head. He fell down on the road outside the doctor's clinic and brought in. Dr. Achen had to treat this boy in his customary 2 to 3 minutes. Took some cotton, located the cut in between. Somebody had put haldi, there was blood and then hair of the head. Applied a dressing, gave tetanus toxoid. And when the boy's mother, who had arrived by then, asked the doctor, "Doctor, his father died of AIDS. I want to do his test. You know where I can do close by?" And that shocked him. He spent horrifying 3 months to clear the window period. Now, these are 2 different types of general practitioners in Mumbai or any other place for that matter. Both are aware of dangers of HIV transmission. One will suffer due to tendency to procrastinate. This first doctor could have gone back and said, "I'll come when there is electricity." And other is so quick, he doesn't think of gloves, he doesn't think of anything. And that is the reason that the topic I have chosen is family physician and HIV/AIDS. If nothing else, my job is to keep myself safe. What are the risks to Indian family physician? We are a one-man industry. We don't have assistants or nurses. All of us don't have. Our so-called assistants are trained by us. So if we are casual, they are casual. If I put on gloves to do a dressing where there is likelihood of contamination or all dressings, then my compounder will use gloves to do a dressing. We are labor intensive. Labor intensive means for every rupee that we earn, no, we have to do some effort. And then we cannot involve more people because that again costs. Very narrow margins of profit. There are universal precautions listed, but we have to also evaluate the cost effectiveness. Now, government has mandated our proper disposal of consumables and contaminated products and all. So then we have to keep those kind of containers. We have to maintain that. And then for a doctor in a low cost area who's charging 20-30 rupees for a dressing, does it justify to use a pair of gloves? I would say yes, it justifies because that saves him. And we are not trained or equipped to provide preliminary care, counseling, or monitoring of HIV patients. See, understand one thing, even if a patient is HIV positive, he or she is going to suffer from routine day-to-day ailments. It's like, a patient of leukemia. Every symptom that patient has is not due to leukemia. And once you say no, that, oh, this I cannot guide you, go to specialist, you kind of lost that patient. And we need proper guidelines for referral and when to admit. So first thing first, which I am very sure all of us know, but I am again repeating, HIV and AIDS are not synonyms. They are two ends of the same disease, two ends at different spectrum. HIV positive patient is this patient has HIV virus in his blood. And AIDS is a disease complex, acquired immune deficiency syndrome. All possible systems can get affected, including certain cancers. Initially in early 90s, when AIDS treatment came to India, it was said that every patient of AIDS, every patient of HIV positive will have AIDS in 10 years or so. But today, most people with HIV don't have AIDS. And if they take their HIV medicine as prescribed, compliance is very important. They may never develop AIDS. I myself have been following up patients for more than 20-25 years. And they are healthy. They have other problems like age-related hypertension, diabetes, arthritis, but they don't have AIDS. Their CD4 count remains high. This is electron microscope picture of an HIV virus. This is the figurative presentation of a HIV virus. You see there are two oval circles, GP41 and GP120. These are glycoproteins in the envelope. This is the virus, this is the cell wall, and this is the genomic RNA with reverse transcriptase. We'll not go into confusion. This is the T lymphocyte. We know that lymphocytes are first barriers of immunity in our body. Lymphocytes can be divided into several subtypes. Two are important for HIV/AIDS, CD4 and CD8. HIV virus attacks and destroys CD4 cells. That is why it kills the immunity of the body, and then because there is no immunity, even the smallest infection can become fatal. This is again a pictorial representation. I won't go into this. The big one is a T lymphocyte. You see from the top here, left upper corner, if you see HIV virus has entered, and through several steps, now it has produced at least two and many such more. I'm going to show you a video. I will not take credit. I will only take credit of having located that video online. Give me a minute. I will locate that video and I'll show it to you.
Targeting HIV replication. The replication of HIV-1 is a multi-stage process. Each step is crucial to successful replication.
See, when we had the 4 Sunday workshop on HIV, I had done a lot of research, and this was the best video I could find, which will explain how a HIV virus infects CD4 and how does it happen. It's a small video, but please see it carefully.
Targeting HIV replication. The replication of HIV-1 is a multi-stage process. Each step is crucial to successful replication and is therefore a potential target of antiretroviral drugs. Step 1 is the infection of a suitable host cell, such as a CD4 positive T lymphocyte. Entry of HIV into the cell requires the presence of certain receptors on the cell surface. CD4 receptors and co-receptors such as CCR5 or CXCR4. These receptors interact with protein complexes, which are embedded in the viral envelope. These complexes are composed of 2 glycoproteins, an extracellular GP120 and a transmembrane GP41. When HIV approaches a target cell, GP120 binds to the CD4 receptors. This process is termed attachment. It promotes further binding to a co-receptor. Co-receptor binding results in a conformational change in GP120. This allows GP41 to unfold and insert its hydrophobic terminus into the cell membrane. GP41 then folds back on itself. This draws the virus towards the cell and facilitates the fusion of their membranes. The viral nucleocapsid enters the host cell and breaks open, releasing 2 viral RNA strands and 3 essential replication enzymes: integrase, protease, and reverse transcriptase. Reverse transcriptase begins the reverse transcription of viral RNA. It has 2 catalytic domains: the ribonuclease H active site and the polymerase active site. Here, single-stranded viral RNA is transcribed into an RNA-DNA double helix. Ribonuclease H breaks down the RNA. The polymerase then completes the remaining DNA strand to form a DNA double helix. Now, integrase goes into action. It cleaves a dinucleotide from each 3' end of the DNA, creating 2 sticky ends. Integrase then transfers the DNA into the cell nucleus and facilitates its integration into the host cell genome. The host cell genome now contains the genetic information of HIV. Activation of the cell induces transcription of proviral DNA into messenger RNA. The viral messenger RNA migrates into the cytoplasm, where building blocks for a new virus are synthesized. Some of them have to be processed by the viral protease. Protease cleaves longer proteins into smaller core proteins. This step is crucial to create an infectious virus. 2 viral RNA strands and the replication enzymes then come together and core proteins assemble around them, forming the capsid. This immature viral particle leaves the cell, acquiring a new envelope of host and viral proteins. The virus matures and becomes ready to infect other cells. HIV replicates billions of times per day, destroying the host's immune cells and eventually causing disease progression. Drugs which interfere with the key steps of viral replication can stop this fatal process. Entry into the host cell can be blocked by fusion inhibitors, for example. Inhibition of reverse transcriptase by nucleoside inhibitors or by non-nucleoside reverse transcriptase inhibitors is part of standard antiretroviral regimens. The action of integrase can be blocked. Protease inhibitors are also part of standard antiretroviral therapy. Each blocked step in viral replication is a step towards better control of HIV disease.
I hope the voice was audible.
Yes, sir.
So actually now you saw how HIV virus turns a CD4 into a factory for manufacturing further HIV viruses. That is the reason, and because of the constant mutation of the virus, we will mostly never be able to find a vaccine against HIV. Why treatments are changing? Because the virus gets immune to certain drugs, and all the steps that you saw, no, there are 7 steps, and 7, if you see here, attachment, fusion, reverse transcription, integration, transcription, translation, assembly, virion budding. There are 7 steps and there are 7 category of drugs to block each step. And that is why we hope to control HIV. So coming to how does HIV transmit? There are 3 ways: direct contact, direct sexual contact, unprotected intercourse, whether vaginal, anal, or oral. So how does that affect a general practitioner? Your skills of asking about anal and oral intercourse, even deep kissing, prolonged kissing, and oral intercourse, male to female, female to male, doesn't make a difference if one person is HIV infected. Second is body fluids, blood products, vomitus, urine, stool, everything. And vertical transmission, if the mother is HIV positive, going to the fetus. Now, something about tests and window period. Now, suppose tomorrow a patient comes to you and says, Doctor, I was in a pub yesterday and I had 6 drinks, and before I could realize I had sex with somebody and I don't know that person. And now he wants your advice. He or she wants your advice and you are stuck. You don't know anything. Should you do a test then? That will be cheating because that doesn't tell you anything. So there are different tests and there is a window period from the time of infection till the test becomes positive. There are 3 types of tests known as antibody tests. Antibody against HIV 1 and 2. We do from venous blood or we can do from finger prick if we are doing rapid test in the clinics, or at times with oral fluid, but we at our level will do only finger prick. Antibody test can take 23 to 90 days to detect HIV after exposure. So first 23 days minimum and 90 days. That's why both the cases that I told you, they waited 90 days before they were cleared. Then there are tests called antigen antibody test. They look for both HIV antibodies as well as antigen, P24 antigen. We just showed you on the virus. It is looked for that. An antigen antibody test performed by a lab on venous blood usually detects HIV from 18 to 45 days after exposure. So we have a 5-day extra window. And it will be later if you do from a finger prick. So always understand the results are better from venous blood. Then there are nucleic acid test, NAT. They look for actual virus in the blood. This test should be considered for people who have had a recent exposure or a possible exposure with early symptom of HIV and have tested negative with an antibody or antigen antibody test. A NAT can usually detect HIV 10 to 33 days after exposure. So if your 10th day test is negative, you do after 15 days, 20 days, 25 days, that kind of a thing. But if 33 days it is negative or 35 days, then you can be almost sure that this patient has escaped HIV. How do we diagnose? The antibody test that we do is generally ELISA test. So we have to do from 2 different kits. If you see HIV report of a government hospital, it will say from kit number so-and-so and kit number so-and-so. Same sample, but to be done from 2 kits and both should be negative. If one of them is positive, then the next is Western blot. This is a very sensitive blood test used to confirm a positive ELISA test. Then, if you are a good family doctor, you may do a viral load. It measures the number of HIV copies. The term is copies. How we do culture, urine culture, we say colonies. For viral load, whether HIV, hepatitis B or C, we call copies in a ml of blood. Generally, it's used to monitor treatment progress or detect early HIV infection. So I have a patient who's ELISA positive, Western blot positive. I would like to do a viral load to see, that is my triple confirmation that this patient has HIV. There are 3 technologies measure HIV viral load in the blood. Just remember the names. You don't have to go into the detail. Reverse transcription polymerase chain reaction, what is commonly known as RT-PCR. Branch DNA or bDNA. And nucleic acid sequence-based amplification assay, either NASBA or NAAT. The basic principle is the same. HIV is detected using the DNA sequence, what we just saw in the video. Important to note that all 3 types may give different values, so we need not repeat everything. A high viral load. Now, if you do a viral load, how do you interpret? A high viral load is generally considered about 100,000 or 1 lakh copies. But patient could have 1 million or 2 million or 5 million also, depending on how advanced the disease is and how close the patient is to AIDS. It indicates the virus is at work, making copies of itself, and the disease may progress quickly. A lower HIV viral load is below 10,000 copies, indicates virus probably isn't active, reproducing as fast, and damage to immune system may be slow. But this is not optimal. This is not desirable. A viral load that can't be detected is less than 20 copies is always the goal of HIV treatment. We want to reach a viral load which is not detectable. Again, for us, some of us who are very assuring to the patient, a viral load not detectable does not mean cure. Then once you are confirmed, you start checking diabetes mellitus. You check for hepatitis B, hepatitis C and VDRL, because if the person has deviant behavior, then chances of other sexually transmitted diseases, hepatitis B, hepatitis C doesn't transmit through sexual activity, but could come from blood and blood products or even infected needles. And VDRL for all other old sexually transmitted diseases. Get a chest X-ray and if positive, sputum analysis, because tuberculosis with diabetes, I always say 1 + 1 = 11. TB with HIV is 1 + 1 = 111. Almost all HIV patients will get tuberculosis. Tuberculosis was kind of eradicated in US in early 80s, but with the advent of HIV, the TB came back in. Diagnosis: once HIV is confirmed, whether patient has AIDS or not, we have to monitor with CD4, CD8 count. CD4 is a type of lymphocyte called helper T cell. I know this is going to be a little toxic to people, but this particular one will be given to you on YouTube, unlimited time you want to see, if you want to see ever. CD4 helper T cells, CD8 killer T cells. CD4 helps our body and HIV destroys CD4. So our immunity is gone. And then ratio of CD4, CD8 is taken out. According to Center of Disease Control, Atlanta, for an authoritative diagnosis of AIDS, CD4 T lymphocyte count should be below 200 per cubic millimeter. There should be a AIDS defining opportunistic infection. What is opportunistic infection? By the immunity of our body going down, there is an opportunity for the infection to enter. So these infections, which are exclusive to HIV, are known as opportunistic infection. They occur because the patient has no immunity. There is no security there at all. PCP, it is a kind of a pneumonia, pneumocystis carinii pneumonia. This is specific for HIV of AIDS. Occurs in HIV patient and its diagnosis shows that patient has reached AIDS stage. Treatment is just cotrimoxazole, oral candidal thrush. In a HIV positive patient, oral candidal thrush will indicate that CD4 is below 200. This could be AIDS. And B cell lymphoma or beta cell lymphoma or similar conditions. This is a report of a CD4, CD8 count. Of course, this has other things also, but what we have to focus on, absolute CD4 count, absolute CD8 count, and CD4, CD8 ratio. This patient is on treatment. We check it every 3 to 6 months based on the patient's clinical appearance. And then if CD4, CD8 and ratio are all within normal limit, we presume that the treatment is working. Treatment, we are never going to be treating, so I'm not going to talk of treatment like that. Antiretroviral therapy is recommended for all persons with HIV to reduce morbidity and mortality and to prevent the transmission of HIV to others. The time when we had done the workshop, there was a guideline that if CD4 count falls below 350, then we should start ART. Till then we should watch. But from 2015 onwards, every patient has to be given antiretroviral treatment to prevent AIDS and prevent transmission to others. So basically, the panel on antiretroviral guidelines for adults, this is in US, they say it should be started immediately or as soon as possible on diagnosis. What's the difference between immediately and as soon as possible? Immediately on diagnosis, you start workup, and as soon as the patient can either afford treatment or refer to a center, you start treatment. Then when it is starting treatment, this is our role to educate the patient benefits of this and how to monitor and why never to stop. See, today, I feel bad to say there are doctors who give patients anti-TB treatment from clinic, thinking that if you tell them TB, they will run away, and the patient never completes the course. And that is the genesis of MDR TB. Treatment adherence is most important. There are 7 classes of antiretroviral drugs, and usually 3 drug combo is given and 2 to 3 drugs for prevention. We'll talk about preventive ART. Pre-exposure prophylaxis. A doctor, this happened to a doctor. They were operating cesarean section. The patient went in seizure. On table, patient had had been intubated. So this doctor tried to open the patient's mouth, and the tooth hurt the doctor's finger, blood came out, and they knew the patient is hepatitis B positive. Of course, the doctor had taken vaccine. But in your clinic, like this doctor, second doctor of our, who touched the child and then realized the child could be HIV positive, or a casual encounter and you want to give treatment, that is called pre-exposure prophylaxis. Is medicine taken to prevent getting HIV? It's highly effective for preventing HIV when taken as prescribed. That as prescribed is a must. It reduces the risk of getting HIV from sex by about 99% and reduces the risk of getting HIV from injection drug use by at least 74%. This is IV drug use, contaminated syringe used. Less effective when not taken as prescribed. Since it only protects against HIV, condom use is still important for the protection against other sexually transmitted diseases. Condom use is also important to help prevent HIV if the prophylaxis is not taken as prescribed. Duration. Very important point. If this is a casual encounter and is never likely to repeat, then you can do NAT and give it for a month. But if the person is going to continue deviant behavior, see, there are people who we may think, oh, there is a medicine, no? So now I can keep having casual sex unprotected with even sex workers. Then this is lifetime. So understand, it is not that you take 1 month and then you are safe for future. And even recommend a condom use for such people because others diseases should not get in. I'm giving some names, but please do not use unless you are very confident of treating HIV patient. Emtricitabine and tenofovir disoproxil fumarate, 2 brand names, Tenvir EM of Cipla and Tavin EM of Emcure. Emtricitabine, tenofovir are for people at risk through sex or injection. Both are for sex or injection drug use. But we cannot give it for females at birth who could get HIV from vaginal sex. So post-pregnancy you cannot give. Tafnet and Tafero. And there is a cabotegravir injection, sexual risk once in 2 months, but not yet available in India. So what is our scope? What can we do for HIV? Initial diagnosis with ELISA, confirmation with Western blot, viral load if you want to really be involved, follow up with CD4, CD8 count and compliance, and counseling. Counseling is the biggest part. What are our risk factors? There are certain risk factors in our clinics which we do not realize. First is our compounder. You know, governments all across the world have promised HIV patients a level of serious confidentiality. That is why HIV positive patients are not known as HIV positive. There is an acronym called PLWHA, people living with HIV/AIDS. So you don't say he's HIV positive, you say PLWHA. So, in our clinics, there is no confidentiality. You are talking loudly, your compounder knows. If the patient is of your area, next day everybody knows. And believe me, you can be taken to court. I must narrate a case here which actually happened. There was a very well-known celebrity in Calcutta. He was a playboy and he was engaged to be married to a billionaire's daughter. So this person was HIV positive. His doctor knew. When the news of engagement was published in the newspaper, the doctor informed the girl's family. This person took the doctor to court, saying that I have a right to confidentiality. How could this doctor disclose? The court decided in favor of the doctor, saying that right to confidentiality is a right, but right to life is a bigger right. So this doctor was protecting right to life of the girl. So understand, HIV is something which you have to keep very closely guarded secret. A man can even take you to court if you tell his wife, but you have to tell his wife because the wife is your patient generally. So, and that is where your communication skills become very important. Our non-verbal communication. If we are of a little different mentality, we start showing disgust on our face. I think that is very bad. Understand one thing, there are certain things we will never do ourselves. But when I'm sitting in a doctor's chair, I am not sitting here to moralize. If a patient comes and tells me he's having an affair with the next door neighbor's wife, my job is to tell them that make sure there are no sexually transmitted diseases, no pregnancy, and think twice what you are doing. You may destroy two families. Beyond that, I am not supposed to moralize on him. And then our tendency, because we don't know anything, HIV, oh, I don't treat, go somewhere. Our main scope is prevention counseling. If I know my patient goes to red light area, today I may be treating him for chancroid. I have to caution him about HIV. Because these youngsters, these teenagers do not know that they can get HIV from deviant behavior. Assessment of high risk behavior. If somebody comes to you and says, doctor, I want to get tattooed done, is it safe? You have to tell him that needle should be sterilized or disposable. So if you have a patient who's a high risk behavior, you have to counsel them on what they can do. Help them acknowledge risk associated. They should understand, they should realize the value of using a protective device. Define how their lifestyle and self-image, most of the deviant behavior is done in self-image. I have a macho image. Others are doing, why should I not do? Peer pressure. You have to counsel them and help them define the potential that you can change yourself. Because once you get it, no, the life is gone. When is counseling required? At the time of initial contact, disclosing HIV status. I wish tomorrow, or maybe not tomorrow, like maybe in a few months' time, this is my wish, to have a practical face-to-face session on counseling where there is a role play, one doctor and another doctor posing as patient. How will you disclose HIV positive status to a patient and his spouse? How will you tell a parent that their 2-month-old baby has leukemia? Breaking bad news is very important skill. So disclosing HIV status, informing others, family members, making decision. See, today, how many of us can actually counsel a patient on diagnosis of cancer, leave aside HIV? Facing reaction of others, crisis, they should not tell people, they should keep it confidential. I will promise confidentiality, you don't do anything. And if the disease progresses and there is death, how are you going to manage that? This is all our scope. This is not the scope of a specialist. And that makes it very important. Verbal communication and non-verbal communication. Our gestures, our expression. You know, most of us, while counseling, tell the patient, I understand what you are feeling. This is the wrongest sentence you could ever say, because you really don't understand what the patient is going through. You don't have HIV positive status, no? How can you understand? Our child has not got leukemia, no? How can we understand? We know what you're going through. Never say that. So this is all I wanted to share about HIV. Today being World's AIDS Day. Now, of course, HIV has become less. Government BMC is giving free treatment. I will not tell you to learn how to treat HIV, but compliance, whether the patient is taking treatment. Every time the patient comes to you, for any complaint, you have to ask whether treatment is going on or not. If patient gets tuberculosis, how to treat HIV? Which one first? Both together. Earlier on, we could say treat TB first, but then no, both together. Non-verbal communication, doctor, it is the confidence you show on your face. And give an example. You're going on the road. You're searching for a particular building. You ask a very well-dressed person, where is the building? That person raises his hand, points in a direction, go that side, right turn after 4th building. The words are very clear, but the way they were said tells you not to trust him. You go and ask somebody else. So non-verbal communication is 65%, 35% is only words. Your facial expression, your gesture, your hand movements. Even if you tell a patient something about, you know or you don't know, patients can pick up whether you are confident or you're not confident. At workplace HIV positive case, how to handle such case? Okay, Dr. Ramesh, if a patient has visited sex worker for time, how to manage them? See, if he's not used a condom, then you have to offer preventive prophylaxis, pre-exposure prophylaxis. Because you can't say, I'll wait and see. No way. at workplace, Dr. Sanjay Mori, I didn't understand. Our clinic HIV positive case or what? If one of your employee has HIV positive, you need not remove them. Let them work there only and treat properly. Isn't it necessary to inform accompanying husband, wife, father, mother about positive status? See, if the patient is unmarried, I would say father, mother, or one responsible member of the family, only one. In a diabetes, you can call the family here only one. And if the patient is married, then spouse. Both parents HIV positive, planning pregnancy, how to guide them? So wherever they are taking treatment, no, the mother can be treated so that the child is HIV negative. That has happened very commonly. So please, you can do. What about HIV positive housemaid? Yes, no harm. Because HIV, like today my team is putting up some posts on Instagram. You can follow life counts on Instagram, LIFECOUNTZ. So HIV does not transmit by handshaking, hugging, using same utensils. No, only 3 positive. And of course, I am very sure that we are not talking of having sex with maid or deep kissing. So you are safe. How many viral copies should be present in HIV positive to declare him as suffering from AIDS? No, AIDS diagnosis is not from the number of viral load. That is, AIDS is from CD4 count or presence of one of the opportunistic infections. Can HIV positive patient use same toilet facility as their family? Yes, they can. Because, it's like people who come and tell you, I got urinary infection, I went to public toilet, we have to tell them the bacteria doesn't jump up. Here, we have to, urine or stool is all going down in the drain. So they can use very comfortably, no issue at all. One point I will tell you here, which we practice in our clinic. And suppose the patient has vomited on the floor. Ordinary bleaching powder in water. So half a bucket of water, about 2 teaspoons of bleaching powder is enough to kill that HIV virus. HIV virus in sunlight will die within seconds. And virus needs a human body to replicate. Hepatitis B virus is hardy. It can survive outside the human body also for years together. See, Dr. Shilpi, using same utensil, even a spoon can be used. Now, even if a patient is not HIV, I will not recommend using a used spoon. Like you may give the spoon you are using to your small child. But then grown-up adults don't use that kind of a spoon sharing, no. But one spoon used, washed, yes, no need to keep separate utensils for them. So although the risk from needle stick injury are less, but let's not get into percentages because the one who gets it, it's 100%. So precaution, precaution, precaution. Next week, we will have the last of our lifestyle management. Then we will see what other topics we can take. Thank you very much for your patient hearing. And please, Preeti, this will go on YouTube for good time. Okay?
Yes, sir.